This is Juha. So I got a quick question for Blanca. I think your data, I'm over here, but your data on the incomplete type intestinal metaplasia was really compelling. And basically I saw there was a 10-fold increased risk of progressing onto gastric cancer if you had incomplete versus complete type. Do you think OLGM needs to be changed to incorporate the significance of incomplete type? Because based on OLGM, you can still have incomplete type but not have it be very extensive. And you theoretically could be, a stage 1 or 2 with incomplete type.
Yeah. The question is if OLGA should be changed?
If OLGM should be updated to incorporate the presence of incomplete type. And there's still a significant resistance to even giving the diagnosis of incomplete type, differentiating between complete and incomplete within the US. We're really lucky here at Stanford. Our pathologists will, report out complete type and incomplete type. But when I, go across the country, most places, the pathologists are still very resistant to doing this.
Well, at Vanderbilt, there is a good pathologist, Kay Washington, and she's already doing it. She says that it's very easy. If they don't do it, the classification is because the gastroenterologists or oncologists don't ask for it, but it's easy to do. So the question about, you were saying that if should incorporate the subtyping, the thing is that either of those will work. Because if you have extensive metaplasia, for sure you will find incomplete. It's very rare to find an extensive metaplasia that is only complete. So either scenario is good for...
But there is a scenario where there's not, there's limited intestinal metaplasia, but there's incomplete type, right?
It's very rare. I mean, the scenario that I was showing that maybe a biopsy that you have only very small foci and is incomplete, that's very rare. Of course, it could happen. But in this case, I would assume that the best way to do it would be do mapping to see if it's actually extensive before you do more surveillance. But yeah.
Other questions? No.
Yeah, excellent talks. Monica, I want to ask you about the Cambridge protocol because it's so many biopsies, I don't follow it. I prefer to use NBI to search for these pale areas, usually in the fundus, and I take biopsy over biopsy. What do you think about this strategy? Because sometimes it's the submucous substrate. Where are you following? And if the biopsy is too superficial, usually you can't get the complete information.
All right. Thanks so much. Great questions. So I think in terms of the pale areas, when you do see a pale area that kind of looks like the patch similar to those photos, it's definitely high yield to biopsy it. I think unfortunately those are more on the rare side. So it's not that every patient that has these foci is going to have these pale areas, unfortunately. So I think it's still critical to do random biopsies, and I do think, at least from what we're seeing from our studies and from other centers as well, that the more biopsies you do, the more chance you do have of detecting it. I think it's a very fascinating question. There's a lot of discussion about what does that mean and how we know most of these patients have these foci in the stomach, right? So what is that, the threshold for detecting it? What does that mean and what does it indicate, and how does that guide our management? And there's some suggestion that perhaps, really staying on top of regular surveillance and the frequency of endoscopy might be more important. But I think that's a really challenging question. So at least from our experience, I think the more biopsies do just statistically give you a higher chance. And I think patients, detecting those signet ring cells does inform patients a bit, and some of them feel more comfortable proceeding with gastrectomy for obvious reasons. But it's a challenge. It's a real challenge, and I think there are a lot of limitations. But I would say that's the one caveat with the pale areas, is that while they're very important to find, and you should definitely biopsy it if you see it, I do think that you're not going to see that in every stomach, so that is a limitation of just relying on that.
Can I follow up? Monica, your slides are great, presentation, fantastic. One thing that I saw on the bottom one slide that I don't know if you had time to mention was to look at the inlet patch. And I thought that was pretty cool because, it's diffuse cancer, high risk. How many of us really look at the inlet patch? And then the other question I had personally is, we talk about signet cell type in diffuse cancer. I've resected some local signet cell cancers by ESD, and should I be looking for hereditary cancer in those patients, or is it just spread?
All great questions. So I guess in terms of the inlet patch, it is in the guidelines. I actually am not sure, maybe our pathologist might have more insight in terms of the actual mechanistic questions. I do biopsy it. I have yet to find any abnormality other than, and then what's noted, but it is part of the actual guidelines. As far as, so the question of diffuse cancer and kind of whether or not it falls into the actual genetic testing criteria, I think that would be again, a multidisciplinary discussion with our clinical genetics folks and kind of discussing the risks and benefits of genetic testing in a patient and whether they qualify. I do think we do have some patients that will have just isolated signet ring cell foci, or they might be incidentally detected on one biopsy, and on a subsequent endoscopy you don't see it. So there are some challenging cases in terms of that fall outside of these real standard categorizations that we have. But I do think that that's where kind of a multidisciplinary discussion and really a discussion with the patient falls in. I would certainly, at minimum, probably follow those patients very closely. But I think it is challenging, and it is something that we see, these kind of disappearing foci, and it's a challenge to find them again, especially in patients that don't have any genetic mutations. So.
I want to follow up on something that Andrew brought up. This is a great session, by the way. And your paradigm that seems to be evolving is consistent with some of the guidelines in terms of who you screen and then who do you survey. And to a first approximation, you might say that there are lower risk groups after the initial screen and then the higher risk group. Of course, there's a gradation. So I wanted to flesh out this thought about once in a lifetime screening, intensive surveillance for the higher risk subgroup, other people may be less intense, which is different, say, than a population health approach like in Japan or Korea, where everyone's getting screened every 1, 2, or 3 years. But it's really the issue of characterizing people well up front, then the intensive surveillance and the ones who are higher risk. Also, what's very exciting is the potential for interrupting natural history, which is now starting to look much more like ablation and Barrett's and polypectomy in the colon, where before we didn't think about that much. It was really, you're finding the cancer as well. If you find dysplasia and you have ESD, then you're affecting natural history. So I really think that's the way this is going to go. You hinted at that, but you said let's talk more about intervals and once in a lifetime. So can you give us more of your thoughts on that? And I'm wondering what the rest of the panel thinks about that paradigm.
Yeah, I'd love to generate that kind of discussion and get everyone's thoughts. I really don't have the answer, but if you think about it, we've taught our fellows forever. If you can just get your patient a one-time colonoscopy, you're saving lives. So it's probably a very analogous situation. Of course, I think surveillance in high-risk patients is indicated, and how you parse it out, if we can get Schalge's biomarker, and I think that would be great, like a gastric Cologuard or something. But I think, I don't think we're there yet, but I think if you just have one screening, it's probably going to be better than none. And so I just don't know what the added benefit, and it might come down to cost effectiveness, but that's not going to help us with the U.S. multi-society. I'd be curious what Rob and
I think the benefit of one screening is that that's what you're using to risk stratify, right? Without that one screening, you can't risk stratify, so you're just guessing. And you need that one exam, and then after that one exam, you can then risk stratify that patient. How much does that patient even have intestinal metaplasia? I think the paradigm that we're going to have in the U.S. is if that one screening is normal, you're done, right? Unless for some reason you have other really high risk factors in your family history or whatnot. But what we're really looking for is to find the premalignant lesions, right? Find the intestinal metaplasia, better characterize that, and then with that characterization and Olgum staging and other risk factors, and ideally eventually biomarkers, then we will be able to better identify, further risk stratify, and determine what your actual interval is going to be.
So one other operational point, maybe that goes without saying, but why would we not do a Sydney protocol on everybody? You know, sometimes you just get one antral biopsy or one antrum in one body. I mean, it's just a couple of more. I don't see a role for that ever anymore, and that's what we used to do.
I still do that. I do. Well, no. So the problem. So it's interesting. The AGI guidelines that we talked about yesterday. They talk about, you know, if you do a random biopsy and you find intestinal metaplasia, do you have to bring them back quickly? But if you do a good exam, and the Japanese and the Koreans know this really well, and they don't even bother biopsying, right? Because they can characterize it without it. But you know, we require our pathologists. If it looks remotely like that there's any intestinal metaplasia, you do Sydney protocol right there. So then you've risk stratified them. You don't have to bring them back. So there's no point in doing that. So it's if you even suspect that there's an abnormality, I do Sydney protocol. Now just random Sydney protocol, I don't know if that's necessary, to be honest with you. If they come in and they're a high risk group, so if they're a high risk group, like if they're in East Asia, I do a Sydney protocol on them. Because I'm looking for H. pylori too, right? So.
Absolutely, but I think our general level of skill in general endoscopy, upper endoscopy in the US is not the same as yours or in the screening programs in Japan and Korea.
That's why the next session will be good. We got AI coming up. So that'll actually help us in the West quite a bit. I have one last question for Andy, and maybe it applies to Doug because he touched on it yesterday, and that has to do with quality. We have great quality markers in colonoscopy. You know, we talk about 7-minute exams now in upper endoscopy. Are we going to have photo documentation requirements as well? What do you think? What do you see as the future of quality in EGD? I think it's a very, very important and hot topic.
Yeah, that's a great one. I know the ASG, I think, has some kind of document coming out. This clinical practice updates. We have something for the AGA coming out. You know, I have a slide that I didn't use, but the stomach's got 40% the surface area of the colon the last time I calculated it. You know, now we're supposed to do colonoscopy for 8 or 9 minutes. And, you know, like people like pride themselves for doing a 3-minute EGD. So there has to be some kind of quality. Where that cutoff is, I think we'll have to like look at some of the numbers. But, you know, I think a 7-minute complete EGD like in the Singaporean study is not too much to ask. You know, looking at the esophagus, stomach, and duodenum, cleaning it, I mean, you know, and I think if you're fast with your documentation, I mean, a 10-minute EGD is not long. And so I really do think, you know, it's like the classic idiom, you know, patient comes to you and your day is crazy, but for them, it's the most important part of their day. And so it's, you know, this may be their one EGD, and so I think you should make it a good one. In terms of more particulars, I do think photo documentation will be important. But, you know, I think we kind of have to group it all together, and it's not just going to be the stomach. Doug?
No, that's a great point, and we are at a sweet spot in terms of time, a time point in terms of changing practice in the U.S. The fact that the ACGA, ASGE quality indicators for upper endoscopy, that document will come out next year. That will influence GI Quick, and that will set quality moving forward. They're essentially currently in the 2015 document, as I mentioned yesterday, there are no quality indicators for the stomach beyond peptic ulcers. So low-hanging fruit, and we anticipate finally being able to move forward.
I think that's it, right? Yeah. One more question. We have one last question.
It's more like an exploratory question and related to the quality and also research, because for colon cancer, everyone started slowing down because of the ADR. So it's also an incentive for the doctors here in America. Everything works as incentive. Is that a way to like use, for example, detection of metaplasia or something as a surrogate for gastric cancer? I don't know if it's a very big push, but try to come up with such a research so we can use it as a quality indicator and also incentive doctors to search at least for it. And also it would potentially be good for the research because sometimes for endpoints such as gastric cancer death, it's very long time. So
I couldn't agree more. I think this speaks to the point about maybe even lobbying and some of the grassroots efforts. Like in our institution, our pathologists have gotten dinged, and I think it may be a MIPS or Medicare thing, but if they stain too many patients for H. pylori, it's actually bad. And so now they've stopped staining people without, any kind of chronic gastritis, and sometimes the H. pylori will go from the antrum to the body. So if I take biopsies from the body and it doesn't look really abnormal, but they're on a PPI, I can't even get my pathologist to stain the body, and so I feel like we were almost losing ground. So what you're saying is totally right, but I feel like, without this kind of advocacy and, meetings and like the proceedings, I think we could lose ground.
I'd also want to add that we just need great data to set those benchmarks and those standards, right? Because I think right now we're doing a big lit review from the SysNet side of things for the modeling, and it's just very fascinating how little data there is that's really targeted, especially at the U.S. population. And so we're left extrapolating a lot from other places. But I think before we can set those benchmarks and really hold people accountable to it, I think we really need to understand what our population is and what those target goals are going to be. So we still have a lot of work to do. But I think that's the ultimate goal. Is it would be great to be able to really have firm, benchmarks to grade people on.
Great. I want to thank all the speakers. Great discussion. Want to conclude the session, and we're going to have 5 minutes break.